Hello, this is Professor Harkirat Bal again. Welcome back to part 2 of this lecture series. In this section, we will go over the treatment approach for a client who's suffering from psychosis. Okay, well, before we really get into the different treatment approach for psychosis or schizophrenia, I think it's important to understand the normal physiology and pathophysiology of the disease. That really helps us to understand the mechanism of action of different agents that we will be using. Which agent do we use, and how do we switch them, and why? When we talk about a pathogenesis, I think it's important to have a conversation on neurotransmitters. So let me share a story of neurotransmitters in the setting of psychosis. So the first hypothesis is dopamine. Now, dopamine is a very important neurotransmitter. That's your key player here. We believe that you have increased level of dopamine. So when you have a neurotransmitter, if this is the a presynaptic cell, if you will, you're going to release a neurotransmitter here. In this case, it's going to be dopamine. And we know that you have here's a postsynaptic cell. We know that you have different types of receptors, right? You have a D1, D2, D3, D4, D5. Now, we believe at D2 receptors, the D2 receptor, you have a hyperactivity, too much. So hyperactivity of dopamine at D2 receptors in the mesolimbic pathway. I am going to talk about different dopamine pathways in a minute. For now, just understand that you have a hyperactivity of D2 receptors. That is your dopamine hypothesis. Okay, well, we knew that dopamine cannot be the only key player. Otherwise, all of the first generation antipsychotic medications will work very well for all of those patients, because all of those medications, they actually bind at D2 receptors very tightly. So they will decrease your dopamine level, and that will take care of the problem. But we know that's not true. It helps some patients, but not all of them. And especially it doesn't help with your negative symptoms of schizophrenia. And so that tells us there has to be something else, right? So even with our twin patients, I said I had twin brothers. Both of them on the same medication, and then one of them actually did very well, and the other one didn't. That tells you there has to be more than genetics. There has to be more than just a dopamine hypothesis. So we believe that serotonin also play a very important role. So it's actually hyperactivity, again, hyperactivity at 5-hydroxytryptamine, which is 5-HT2, more specifically at 2A receptors. So it's easy to remember, dopamine D2, and then with the serotonin, again, you have a 2A, right? So and this time you have 5-HT2A receptors in the cortex. Now, this really explains how second generation antipsychotic medication, how they're able to actually help both positive and negative symptoms, right? So, and they have less side effect, less something that we call extrapyramidal side effect. And I'm going to talk about those things in a minute, guys. So just bear with me. I'm just introducing the neurotransmitters right now. Okay. So far we talked about hyperactivity of dopamine and then hyperactivity of serotonin. Now, next stop is the glutamate hypothesis. This is something new, okay, newer, I should say. So what happened is, recall from my previous lectures that glutamate is an excitatory neurotransmitter. So just remember that, excitatory, right? And also understand that we are talking about schizophrenia, more specifically positive symptoms like hallucinations, delusions, and so forth, right? So what happened is, and I'm going to share normal physiology first, and then we will talk about pathophysiology in a second, okay? So when glutamate is released, it actually binds at another receptor, something that we will call NMDA. So this is your, oops, that's M, guys. So NMDA, N-methyl D-aspartate receptor. Okay, so what happened is when glutamate is released, remember it's excitatory, so it's actually going to work on something that we call GABA. And remember, GABA is your inhibitory neurotransmitter. It's opposite of glutamate pretty much, right? Remember, glutamate is your on switch and GABA will be the off switch. So glutamate, when is released, it will bind at the what do you call it, GABA, and then GABA will be released, and GABA is going to inhibit. It's going to have inhibitory effect, and that's a good thing. That's what we want, right? That's normal physiology. However, glutamate hypothesis states that we have hypofunction at NMDA. That means this, let me use a different name, this is not working properly. There's a hypofunction. So pathophysiology is when you have glutamate is released, but then you have a hypofunction where this was going to bind. Now it cannot bind, and therefore you're not going to release GABA. And what happened, as a matter of fact, is that you actually have excessive release of glutamate into the cortex. Then you have too much of a glutamate, and glutamate is excitatory, and that is not a good thing when you have a client who's already suffering from psychosis or schizophrenia. Now, next similar approach is GABA. Now, we talked about GABA already, right? Gamma aminobutyric acid. So according to this theory, you have hypoactivity at the prefrontal cortex. Remember, GABA was going to be the brake pedals for you, right? There's a lot of research going on now for on a glutamate hypothesis, and then evidence come from the fact that we have ketamine, that we know that it plays a very important role at NMDA receptor, and it can cause psychosis. So that really gives us a clue, and perhaps we can develop medications to target this neurotransmitter instead of just working on a dopamine. Now, next very interesting neurotransmitter is acetylcholine. Remember, acetylcholine is part of your cholinergic system. Remember, parasympathetic. Remember, sympathetic was your like a norepinephrine, epinephrine, and then you have a cholinergic branch. Acetylcholine was the main key player, right? So we believe that cholinergic activities really helps with cognition. And the opposite is also true. When you have a low level of acetylcholine, you may have a cognitive impairment. And recall from, again, my previous lectures that acetylcholine also binds at two different type of receptors. You have muscarinic, M1, M2, M3, M4, M5, and so forth, right? And then you have a nicotinic. Remember, nicotinic receptors. Now, even though both receptors play important role, but more specifically, at least today for this lecture, we are interested in the muscarinic receptors, and we believe that it's a hypoactivity, low level hypoactivity at M4 receptors may cause these symptoms. And now we have a newer drug. I'm going to talk about that agent in a few minutes or so, that targets specifically muscarinic or acetylcholine receptors, I should say. So this is really exciting time, guys, when we have a different drugs that are targeting different neurotransmitters. So remember, this is cholinergic. So think of this as a procholinergic agent, okay? Do not get confused with anticholinergic. Anticholinergic will be opposite of this. That means if you're blocking acetylcholine, you are actually decreasing cognitive function, right? That's blunting. That'll be opposite. That's not what you want. So this is a procholinergic drug, and we will talk about the agent in a few minutes, as I mentioned before. Okay, so the next stop is a trace amine associated receptors, or TARS. Now, this is not a true neurotransmitters, if you will. This is a type that is similar to your monoamine neurotransmitters. Remember, monoamines were your dopamine, serotonin, and norepinephrine, and so forth. So that was that class, right? So it's structurally similar to that, but these are not necessarily true neurotransmitters. Well, it's actually they belong to G protein coupled receptor. What happened is, we believe that if you work on something that we call TAR1 receptor or TAR1 agonist drugs, when those drugs bind at these receptors, they will decrease the firing rate of dopamine, and more specifically in the ventral tegmental neurons area, and it will also decrease your serotonin and modulate glutamate. So that's exciting. This is actually a new or a very emerging class, you can say, with the potential antipsychotic effect. And I'm actually very, very excited and looking forward for these drugs to be approved, and hopefully will help our clients from a different angle instead of a traditional approach to treat them by binding at the D2 receptors, if you will, because those drugs, I mean, we know antipsychotic, especially the first generation, they do have a lot of side effects. So this is exciting. Okay, now pay attention to this slide. In my opinion, this is one of the most important concept in this lecture series. So make sure you're taking notes. Remember in my previous slide when I was talking about different hypotheses, and I said under dopamine hypothesis that you have a hyperactivity at a D2 receptors in the mesolimbic pathway, and I said we will talk more about different dopamine pathways. So this is the slide, so make sure you take notes. Very, very important concept. Okay, so we'll start with, take a look at the diagram of the brain on the left hand side, and see where you have VTA, something that we call ventral tegmental area, and some people read this as where trouble arises, and then trouble in this case will be psychosis, of course. So we'll start our story from this area. So what happened is, along with VTA and your nucleus accumbens area, we'll call that mesolimbic area. So right here, I'm going to draw a circle, and that's number 2. I'm going to start my story with the number 2 for some odd reason. Now, remember in normal physiology first, we'll do that first. When you have dopamine level, dopamine in this area, it will help us to maintain our emotions, you can say. So you can say dopamine play a very important role in mesolimbic pathway as far as the emotions are concerned. So that's a good thing, right? Now the problem is when all of a sudden you have too much of dopamine here. So too much. Remember, I said it's a hyperactivity. So too much of dopamine in the mesolimbic pathway can result in something that we call a positive symptoms of schizophrenia. Now, if you haven't watched my part 1 of the lecture, please make sure you do that and have a very good understanding of positive and negative symptoms. Otherwise, you will struggle with the rest of the chapter here, or rest of the lecture. Okay, so if too much dopamine is causing positive symptoms here, that means the treatment will be to decrease dopamine at this level. So that makes sense. All antipsychotic medication, at least the first generation antipsychotics such as Haldol, will actually decrease dopamine level here. So just remember the big picture, that you have increased level of dopamine. Just remember that part, right? Overall you have increased level, right? And our goal here is to actually decrease dopamine level here so that we can help our client who's suffering from a positive symptoms of schizophrenia, to treat positive symptoms, right? Now, second stop is our let me grab this thing. Okay, so second stop would be prefrontal cortex, something that we call mesocortical area. Now from here to here, we are gonna change our focus. So dopamine plays important role in motivation in mesocortical pathway. Motivation, pleasure, reward. So that's a good thing. I mean, we like to get motivated, if you will, right? However, when you have a client who's suffering from schizophrenia, we know that they actually lack motivation. They're not able to do ADLs. They have no energy to do some task, right? And some people unfortunately often call them lazy, and that's not what's the word I'm looking for? That actually add a stigma to this, right? So so we need to understand the pathophysiology behind it. So anyways, so what happened is here you actually have low level of dopamine. That is the reason we see lack of motivation. So if you want to help your client, you actually want to increase the dopamine in this area, right? So, and that would be a problem if you have, when you give a client first generation antipsychotic medication, their job is to bind at dopamine D2 receptors very tightly, and it will actually decrease your dopamine level throughout the pathway. That means first generation medication will actually increase your negative symptoms. It will not help them, right? Make them even worse. So that's not a good thing. So so just keep that in mind, please. Okay, number 3, the third stop here is, I'll use a green ink here, is your nigrostriatal pathway. SN is for your substantial nigra, and then your basal ganglia. Now, I am actually going to introduce a concept of EPS and the role that basal ganglia play in a few minutes, but for now just understand that in a nigrostriatal dopamine pathway, this is where dopamine plays very important role in the movement. Okay, so you need a dopamine in this area. So when you give them antipsychotic medication, you're actually decreasing dopamine here, and therefore we are causing EPS symptoms or side effect of the medications, pretty much, right? And that's not a good thing. So a good approach should be give them a drug where we actually decrease dopamine at this level, at a mesolimbic level. We increase the dopamine at mesocortical level, and we do not touch this area at all at a nigrostriatal level, so that we avoid any side effects, right? And more specifically, your motor disorder side effect. So remember, it's a similar pathophysiology for Parkinson disorder, right? They actually have a decreased level of dopamine in the basal ganglia pathway, or nigrostriatal pathway, I really should say, and that helps us to actually understand how increased level of too much of dopamine can cause psychosis, and decreased level can cause Parkinson. And one point I'm trying to make here is, when we treat our patients for psychosis with antipsychotic medication, the side effect of that agent is sometimes can be your Parkinson type of symptoms, right? We're going to talk about that, drug-induced Parkinsonism. So DIP, we used to call EPS. Okay, so, and the opposite is also true. When we treat a patient who's suffering from psychosis with a medication like levodopa to increase the dopamine because you have a low level of dopamine. And that is the pathophysiology for Parkinson, right? So you're trying to increase a level, and those medication can cause a psychosis. So it's very interesting that one medication is causing the other symptom, if you will, and vice versa. And that really helps us to give evidence that our hypotheses are, we're on the right track with those hypotheses, if you will. Okay. Now the last stop here is going to be your tuberoinfundibular. Now, in this pathway, you see a role of dopamine in prolactin release, hyperprolactinemia, and that also play a very important role in milk secretion, and just overall sexual dysfunctions. Maybe we'll talk more about the side effect of those medications. In men, you see gynecomastia, so that's breast enlargement. So you see those type of symptoms. So an ideal drug should not touch this area at all. So in other words, do not mess up with the prolactin level, right? So that's that. Now the last one here is actually it's not on the list. On the right hand side is your thalamic dopamine pathway. It is questionable. We still need more research, but we believe dopamine may play a role in sleep and arousal. There's no evidence of abnormal function in schizophrenia, but I just wanted to introduce that concept that that is another dopamine pathway called thalamic. All right. Okay, so in this slide, everything that I said is given to you, so make sure you read this and take notes. Okay, so now finally, let's talk about treatment approach. Now, you kind of sort of know the dopamine and serotonin and glutamate and so forth, acetylcholine, so things will be much, much easier now. Now, before we really get into the actual drug, I know you're eagerly waiting for that. We should have a clear goal of our treatment. We should know what exactly we are trying to treat here, what are we exactly trying to achieve, and our patients should know that, right? It should be a collaborative approach. Now, I understand in case of emergency, especially when we are in psych facilities, inpatient, unfortunately, we are the one making all the decisions, and maybe rightfully so at that time. The goal is to keep our patients safe, right? But as outpatient, especially remember you're diagnosing these patients early on in their 20s, and this is going to be a lifelong diagnosis for them, right? So they should have a very good understanding what exactly we are trying to do with the medications and so forth. That with their clear expectations, and we must involve family members as well. It's honestly, generally speaking, it's a multidisciplinary care. You need everybody on board and with the clear expectations. The overall goal is to really avoid any relapse, support them all together so that they can live very healthy as a productive member of the society as much as possible. All right. Now, I know that usually when we talk about any disease, we say that we consider non-pharmacological interventions like a healthy lifestyle and so forth. That's a good from a preventive measures, but unfortunately, it's just the nature of the disease here with the psych, with the schizophrenia more specifically. Sometimes it's not possible to initiate non-pharmacological interventions like a psychotherapy, more specifically, let's say CBT, because that really requires some cognitive response, right? The patient has to be alert enough to follow instructions and able to work on those homework assignments and so forth. Sometimes that may not be practical. So almost always, in my opinion, we use psychotropic medications, and rightfully so, at least in the beginning. And the goal is to introduce a CBT as early as possible so that we can really support them, in my opinion, when psychotherapy is introduced in a timely manner early on, and it's actually very effective. It really helps the patient to work on both positive and negative symptoms. For example, CBT, the goal should be to really understand that these are delusional thoughts, right? Of course, medication will help a little bit, but that thought process will be much better if we introduce a CBT and help with those negative symptoms. Give them a task. What are some things you used to enjoy, and can we work on them one step at a time, of course, and also involve a family member. I think it's so important. A patient family needs to know that when they're going through negative symptoms, they're not being lazy. Remember earlier I said dopamine play a very important role in your of course with emotions and motivation and so forth. But if we are decreasing dopamine with the medications to avoid positive symptoms, we are inviting negative symptoms at that time. So family member needs to know that their loved ones are not being lazy, so please do not add more stigma to it. So just maybe acknowledge that perhaps it's a warning sign that all of a sudden my loved one is not interested in swimming or whatever they used to enjoy, dancing, and perhaps call the provider. Perhaps we need to adjust some medications. So it's very important to involve family members and let them know how they can help with the coping. Patients should come up with the strategies, either listening to their music. We should have a list of their music ready to go, or whatever their coping skills are. We don't tell people what to do. We ask them and they come up with the strategies. We give them some tools, and their job is to identify their own coping strategies and whatever defense mechanism they're using. All right, and then rehab. I think it's a very important concept, as we know that, of course, not all patients, but a lot of patients, they struggle to really fit into the society. Are they able to finish their college or high school, let's say, or college degree? Are they able to apply for a job and maintain that job? So this is a huge burden altogether, not just for the patient or the family, but overall as a society. And we spend a lot of time on this concept. Now, finally, we're going to talk about antipsychotic medications. Okay, so what I have in front of you is I created this table. On the left hand side, you are going to see different items, and the first in the middle maybe the column is first generation antipsychotic medications. We also call them typical drugs. Now you kind of sort of know now. I think it's going to be much easier for me to lecture on this slide. That first generation medication, these are older drugs. They're very old and they are very effective, don't get me wrong, and they're very cheap. They've been on the market for years, and they're very good at treating positive symptoms. So the way I remember, positive symptoms are typically managed with the typical drugs, right? So these are typical drugs, the first generation, and these are the examples in front of you. I'm sure you have heard and seen the first drug a lot. We use this a lot in medicine, in the ER and so forth. Haldol, haloperidol, thorazine is used quite frequently. And just remember that all of the first generation antipsychotic medication, they bind at D2 receptors. They're very potent. They bind very tightly, and they decrease dopamine level, pretty much, you can say, right? So that's very easy mechanism of action. If in one sentence, if somebody asks you, I'm oversimplifying, of course, what's the mechanism of action for first generation antipsychotic medication, you can say, well, they bind very tightly, very potent D2 receptor, dopamine antagonist, of course, right? Okay, now because they bind very tightly, and we talked about different dopamine pathway, now you know that they can cause some other symptoms, right? More specifically, your extrapyramidal side effect. And we are going to talk about these side effects in depth in a few minutes, but I do want to introduce a concept of a second generation antipsychotic medication, and then we'll circle back to these side effects. We'll do the side effects at the end, okay? Okay, so now let's talk about the second generation antipsychotic medication, or we call them atypical drugs. Remember, the first generation were typical, they were older, they were cheap. Atypical are going to be newer, they're more expensive, and they have less side effect. Okay, so the main difference between the first and the second generation is going to be their mechanism of action. Remember, with the first generation, I said they bind very tightly. It's a potent D2 antagonist, right? However, the second generation, you see, even though you do have a D2 receptor antagonist here, but it's not as strong, it's not as potent. So it's actually weaker, and that's a good thing. That means we are not going to decrease the dopamine level in all of the pathways, right? So that helps us getting rid of those EPS type of symptoms that we will get through first generation. And on top of that, we see serotonin receptor antagonist as well. It will actually decrease the serotonin. So the more specifically, the receptor is going to be 2A. And two ways to remember is, so interesting, is a 2A, and 2 ways to remember is A. Remember, with the dopamine, it was a D2, so you get that 2A, and that's serotonin. And then another way to remember is it's a second generation antipsychotic, so 2A is a second generation antipsychotic, 2A. Anyways, I hope that helps. Now, some of the second generation antipsychotic medications, they also carry this anticholinergic and antihistaminic activities. So remember, cholinergic is your acetylcholine, right? And when you have too much acetylcholine, that's you like everything is running, like a runny nose, and GI secretion, mouth is watery or too much saliva. That's a cholinergic. But this is anticholinergic. That means everything will be dried up, anticholinergic, right? So dry eyes, dry mouth, constipation, urinary retention. So you see those type of side effects from some second generation antipsychotic medication, and antihistamine, like a sedation type of a deal, right? Okay, because of this unique mechanism of action, we believe that they are able to manage both positive and negative symptoms of schizophrenia. Now, if you only have a positive symptom and you really want to treat somebody, let's say in the ER, and then focus on just acute episode, first generation medications are still used in that setting, because they will take care of your positive symptoms, such as like delusions, hallucinations, in the ER, let's say. And we can actually give them either Haldol, if they're able to take by mouth, great, or maybe sometimes IM injection and so forth. It works very well, and we still use it. Now, if I'm going to start somebody for a long-term treatment, most likely I will use a second generation, because it's a long-term game and I want to minimize the side effect. Now, you most likely you will see first generation drugs as long-term agents as well, and we do that, by the way. Even as a monotherapy, I've seen this a lot. But if I want to start somebody, most likely I will start them on a second generation. They are more expensive though. All right, so let's talk about some examples. We can actually group them together. I know there are way too many. We can group them together the way they sound, if you will. So look at the first line here. All of them pretty much end with pene, clozapine, olanzapine, quetiapine, asenapine, right? So that's your generic names, and in the parentheses I gave you for clozapine, it's Clozaril, that's the brand name, and olanzapine is Zyprexa, and Seroquel is a brand name, and Cephras is a brand for Cenapine. Now, I do want to make some important points for these individual medications. I'll do that, but let me read these names real quick. So this would be your first group. I'm not saying this is go-to medication, by the way. They're just listed first on this slide. Then you have a medication that ends with a dones, risperidone, brand name would be risperidone, paliperidone, brand name Invega, and so forth. Just go down the list. And then you have another agent called aripiprazole or Abilify, and so forth. So now let's talk about these agents a little bit more in depth, if you will. First one on the list is clozapine or clozaril. Now, just because this is the first agent listed on the screen, that does not mean this is the first line treatment. As a matter of fact, this is almost always the last resort. And the reason behind that is, number one, this medication works very well, by the way. This is a great medication. Out of all the medications, this is the only drug that we believe will decrease suicidal attempts or suicidal ideations for the clients suffering from both schizophrenia and schizoaffective disorder. So very important concept. If you have a client with, let's say, multiple attempts and they have failed other treatments, then we should consider clozapine. Usually we use this treatment as like a last option, last resort for resistant schizophrenia. And a resistant schizophrenia will be when you have tried 2 or 3 agents, you max the dose and then patient still has symptoms, then it's worth trying a clozaril. Now, why is this not a first line treatment? Well, the main issue is going to be it requires blood monitoring, CBC, more specifically ANC, and I'm going to talk about that concept in a few minutes. So it will decrease your ANC level, and sometimes that can be very dangerous. So it requires weekly monitor, and that can be a problem. Now, I practice inpatient, so for me it's much easier. We have in-house lab, if you will, or well, not in-house lab, but the lab comes in and they'll take care of the blood work for me. Now, but for outpatient, that might be a problem, especially if the client doesn't have a transportation. There's so many barriers with the blood work, right? So usually outpatient, clinicians hesitate because it requires a lot of monitoring. There is talk at different levels that to change the policy, if you will, instead of getting weekly labs, just get the baseline and then monitor and then do the lab if needed, because we believe that risk of not prescribing this medication as outpatient because we can't do the lab actually is not helping our clients, because there are patients, they'll in my opinion they'll do very good when we start these medications, and unfortunately they're not getting that benefit because they may not have access to labs. So just like any clinician will keep a close eyes on blood work and so forth, and we believe we can actually leave that up to the provider, and they should be able to start the medication without having to do the labs on a weekly basis. Most of the time, I have so many patients on clozaril, on any given day, and it's very rare that at least in my practice, it's very rare that I see serious abnormal ANC. I do come across, don't get me wrong, once in a while I have seen as low as like a 0.5 or so, and that's bad, I get that, but I do monitor frequently. Anyways, the another issue with most of the antipsychotic, I'm going to make a few points that apply to all of them pretty much, and not just for clozaril, by the way. Any antipsychotic medication can decrease ANC level, by the way. So we should get a baseline CBC for before we start medication, just so you know. So keep an eye on the ANC. But it's a required for clozaril. Just keep that in mind. Okay. Now, pretty much all medication can cause they carry like increased risk of seizures, if you will, especially if the patient actually has a history of seizure. It will decrease the threshold. I personally do not believe it can cause a seizure. It's gonna decrease the threshold. So if you have a history of seizure, you have to be very, very careful. Almost all antipsychotic medication, second generation medication, can cause increase your lipid level, triglycerides, insulin resistance, weight gain, so that metabolic syndrome, if you will. Almost all of them carry the risk for orthostatic hypotension. Now, some of them carry more risk and some of them less, and you can look it up. But overall, just understand that concept that these medications can cause a sedation. They can cause a new onset of diabetes. They can cause a cardiac arrhythmias, like a prolonged QTC interval. I will record a lecture on QTC, the concept of cardiac arrhythmias in the setting of antipsychotic medications. I'll do that in a couple of weeks. So anyways, my point here is that these medications are heavy duty drugs. Make sure you monitor blood work very, very carefully. Now for olanzapine, I do prescribe this a lot. The guidelines are actually we should start with the second generation, but not do a clozapine or olanzapine or quetiapine as a first line. Usually we recommend a risperidone or risperidol, or maybe Abilify, especially as an outpatient. But it's not that you cannot do olanzapine. Sometimes I do it, but the guidelines are really to skip these. But for olanzapine, most of my patients, they tolerate this medication very well. As a matter of fact, I do have that as a PRN as well. They can ask for it if they're having increased episode of hallucinations and so forth. It's very, from structure standpoint of view, it's very similar to clozapine, but it does not require weekly CBCs and anything like that. And none of the other medications require weekly CBCs, only the clozapine does. Now, clozapine also comes as, not clozapine, I'm sorry, olanzapine, Zyprexa, also comes as a sublingual, like a Zydis. So you can put that under the tongue if the patient is having difficulty swallowing, or patient has nausea, vomiting, and stuff like that. Let's see. With what else? Okay, with Xanapine. Xanapine is the only drug that comes as like a drop. It's a what do you call sublingual. So make sure the patient doesn't eat or drink within 10 minutes or so to avoid any first pass metabolism. I don't prescribe this too often, but one of my patients in the past, a couple of years ago, she was on it, and then she told me that it actually, she didn't like the feeling in her mouth. Just like a sensation around the tongue and so forth. So she wanted me to discontinue that. So that is a real phenomena. I have read that, and my patient told me that as well. So I think I switched her to risperidone, and she did very, very well with that. Okay, talking about risperidone now. I prescribe this again a lot. Good drug. It can raise prolactin level, so we have to be very careful. Gynecomastia. It can cause weight gain as well, dyslipidemia. It also comes as ODT, liquid, long-term injections, and so forth. So that's good. That's a good thing about risperidone. We have so many options. Now, paliperidone has been my favorite lately, just because it comes as injections, long-term, like monthly injections. I'm going to talk about that concept. Paliperidone is very, very similar to risperidone. I don't do Geodon too much. There was a issue back in the days with the QTC prolongation, and then I lost interest. So that's a controversial now, but I don't think I have that many patients on it. All right, let's see. Okay, Latuda. It's the main thing is make sure you have your patient eat when you take this medication. So that's important. At least like a 500 calorie food, just like a Geodon. It's a similar concept. All right, let's see. Oh, I think I skipped FNAPT. It is a newer medication. I think it's more expensive. It's newest, I should say. Low level of EPS. It's moderate weight gain, so that's a good thing. It doesn't really. What's the word I'm looking for? Well, it can cause a QTC, but it's a dose dependent. Let's see what else I want to tell you here. For Cableta, it comes in just one dose, 42 milligram once a day, so that's that. Abilify, a good medication, especially as an outpatient. I do inpatient, so sometimes I need to prescribe heavy duty or something stronger. So we do bypass Abilify. We go straight to risperidone and olanzapine, and even clozapine. But as outpatient, good medication. It actually comes as a long-term injection as well. So that's the beauty about aripiprazole, Abilify. Brexpiprazole is expensive, that I know. A good drug, by the way. I personally have no special connection with one drug over the other. No financial ties, just so you know. Okay, next is Raylar. Again, good drug, low incidence of EPS. It is due to partial agonist drug. What else I want to tell you here? Nuplazid. Your pimavanserin. Now, this drug is approved for psychosis in the setting of Parkinson's. So Parkinson's disease, psychosis associated with that, not dementia, not in the setting of dementia. So if you have a client with a dementia, psychosis due to dementia, none of the psychotropic medications are actually approved. As a matter of fact, we have FDA warning for all of these antipsychotic medications that we have to be very, very careful because they carry a huge risk of increased mortality rate for a client who has psychosis secondary to dementia. But for Parkinson, psychosis due to that, we do have Nuplazid. All right. I actually want to go back to Seroquel, quetiapine. This is a very interesting drug that it comes in a different strength, of course. And when you have a smaller dosage, small strength like a 25 milligram, 50 milligram, that strength is not going to help you with psychosis. So that is not the correct dose. So with that strength, it will help you with like insomnia, those type of symptoms. It will keep you calm, like a sedation, especially if you're taking at nighttime. And I'm guessing if somebody's taking it for insomnia, it will be at nighttime. Not that I will personally prescribe Seroquel for insomnia, especially not as a first-line treatment. Not a good practice, but I've seen that a lot though. So, but if you keep increasing the dosage, let's say, I don't know, like a 300 milligram or so, and that's a good dose for antidepressant type of symptoms. Okay, in order to get the antipsychotic effect, the dosage has to be a little bit higher. So, like, I don't know, like 800 milligram or so, and Dr. Strauss talk about this concept in his lecture series as well. And then I think I do have a picture that came directly from his textbook, and I'll share that to make my point that how one drug based on the dosage can have a different indication: insomnia, depression, and antipsychotic. So this is the one that I was talking about, how Seroquel, quetiapine comes in a different strength. So this picture, I'm going to give credit to Dr. Stephen Stahl. He's the psych guru, if you will. So 50 milligram is a hypnotic dose, and 300 antidepressant, and 800 milligram as antipsychotic. So if you're giving, I have seen 25 milligram, 50 milligram, and the diagnosis is schizophrenia, and then that is not, either you don't have a correct diagnosis or you do not have a correct dosage. So be very, very careful, please. Okay, so far we have talked about first generation antipsychotic medications that works primarily on D2 receptors, and then second generation antipsychotic medication that works on, of course, the D2 dopamine and then your serotonin receptors. Now, third classification is acetylcholine, more specifically muscarinic agonist drug, and this is a brand new classification, if you will. We just got approval, FDA approved Cobenfy, that's a brand name, to treat these symptoms from a new neurotransmitter pathway, if you will. The generic name is, it actually consists of two drugs. The first one is xanomeline, and the second part is trospium chloride. Now, the exact mechanism of action is unclear. However, what we believe is that the first part, xanomeline, acts as a muscarinic agonist. In other words, it will actually increase or mimic the activity of acetylcholine. Remember from previous slide, I mentioned when I was talking about different neurotransmitter pathways, I mentioned that low M4 activity is linked with a cognitive impairment, and so we want to increase that, right? So this medication will mimic, its agonist, it will mimic the effect of acetylcholine, and more specifically, it's a selective. It will activate M1 and M4 in the brain, so that's important, right? Now, the issue with when you have too much of acetylcholine, remember that's your parasympathetic. So parasympathetic is all rest and digest. You have a lot of GI activities, the GI secretions, right? Watery eyes, runny nose, mouth is watery. If it's too much, then drooling, which I see sometimes when I prescribe some other antipsychotic medication as a side effect. So the patient is drooling. So nausea, vomiting, diarrhea, that's all because of too much of acetylcholine. So so this drug, they knew that this will carry a risk. So what this is so beautifully done that they actually added trospium chloride as a second agent, and this will act as an anticholinergic. It's going to be muscarinic antagonist. It will stop the activity. Now you may ask, well, what's the point of taking xanomeline, increasing acetylcholine, when trospium chloride is added and it's going to cancel things out? Well, here's the beauty about this drug, that the trospium chloride here works in peripheral tissue. It does not enter in the brain, so therefore it does not have any negative impact, if you will, right? So it will actually enter in peripheral tissues and minimize or decrease your side effect that we'll get from xanomeline. So those side effects are like a nausea, vomiting, diarrhea. So you get rid of these. So in my opinion, that's beautifully done. It is expensive medication. It's just brand new. We just got that approved. It will be very interesting. I'm very excited to see a result, because it's always a good idea to have more tools in the bag, if you will, and then treat our patients from a different angles, and I love stuff like that. So this is neat. Okay, so now let's talk about how to manage those side effects. Remember, this is important because our responsibility is not just to treat either positive or negative symptoms of schizophrenia, but to treat those side effects that comes with these medications, right? These medications, unfortunately, for most people are going to be long-term treatment. We cannot just discontinue medication simply because they have side effects. So sometimes we need to continue the medication or adjust the dosage, but do something about the side effects as well. Very important skill to have. So the first one on the list is anticholinergic side effects. Now that is, we talked about this acetylcholine being as a key neurotransmitter in the cholinergic pathway, and when you have too much of acetylcholine, everything is running, right? Runny nose and diarrhea, nausea, too many secretions, right? Peristalsis, and that's what causing abdominal cramping and diarrhea, loose stool, and so forth. But this is anticholinergic. That means you're blocking it. Now everything is slowed down. So now you have constipation, dry mouth, blurry vision, you're retaining urine. Remember M3, which is present in the bladder, and under the influence of acetylcholine, M3 makes you pee, remember? So if too much acetylcholine makes you pee, but this anticholinergic, you're stopping it, that means you're not able to urinate. That's a urinary retention. All right, next is orthostatic changes. Now, very important concept. Some drugs, especially your second generation medications, such as your clozapine or risperidone and even paliperidone and those drugs, they are more of like an alpha blockers, alpha-adrenergic blocking effect. And again, hopefully this is just a recap. We talked about this concept that when you have a blood vessel and with alpha 1, you will see vasoconstriction. It will alpha 1 will cause increased blood pressure, right? Vasoconstriction. Now, I mentioned that those antipsychotic medication can be alpha blockers. So that means if they're going to block alpha 1, you're going to see the vasodilation effect, and that will decrease the blood pressure. So all of a sudden you see orthostatic changes, orthostatic hypotension, and to compensate, you will see tachycardia along with it. So then, of course, you want to decrease the dosage, perhaps change the medication. Now, I usually do not switch the patient from one agent to another just because they have a side effect, as long as the side effects are not dangerous up to the point like anaphylactic reaction, of course, like a swollen tongue. I'm gonna stop it, right? But for minor things, if it's not too much, I would decrease the dosage, especially if the medication was working to manage their symptoms, though, because that's important, right? But if I have to switch, of course we will switch. Okay, another important concept is your metabolic dysregulation. Now, with metabolic dysregulation, almost all of the second generation medications, they carry this risk of weight gain. So I highly recommend before you start the medication, you get a baseline weight, and then monitor their hemoglobin A1C. I do it every 3 months. 6 months is fine. Sometimes annually if everything is fine. Lipid profile. At least more frequently during the first year, and then maybe annually after that. In my facility, our protocol is to monitor very, very, very frequently. Some medications like olanzapine, Zyprexa, you can gain up to 30 pounds or so in 1 year. That's a lot. So think about it. All of a sudden they have on top of schizophrenia, now they have another disease that that pretty much like we caused because of these medications, and some patients they'll read on these medications, especially when they're stable, and nobody wants to take a medication that can cause diabetes or increase your lipid panel and so forth, or a weight gain for that matter. So be careful, and then do a very good patient teaching, and then adjust your dosage. The idea is not necessary to have your max dose. For example, olanzapine, the max is 30 milligram per day, and if you can manage the symptom with 5 milligram, great, maybe 10, 15. You don't have to go all the way to 30, especially if you are getting weight gain. And then if you are getting a lot of weight gain, then switch the medication. It's not worth it at that time, right? Cardiac arrhythmias, not all of them, but most medication can cause prolonged QTC intervals, especially with the Geodon. Quetiapine, which is Seroquel, can also cause QTC interval. I believe there was a FDA warning on that, or at least the package insert warning. I'm sorry. In my opinion, and I have read that, in few studies, aripiprazole, which is Abilify, maybe safest second generation antipsychotic when we talk about a QTC prolongation. I am actually going to lecture separately on QTC prolongation, so we'll take care of that later. And the next is prolactin level. Now, in men, in male population, the issue will be gynecomastia. In female, of course, breast milk secretion, galactorrhea, menstrual disturbances. And in both male and female, you'll see potential sexual dysfunction. And some people do complain, and it's worth listening to them. And for some patient, for a male patient, gynecomastia is a big deal. For some of them, they don't care as long as the symptoms are managed. So it's a really individualized care. So we have to be careful and listen to their concerns. And otherwise, they're going to be non-compliant if we do not make changes. And I already talked about seizures. It's a dose-related reduction in seizure threshold. Again, I think I mentioned earlier that I do not believe that it can cause seizures, like a new onset. If the patient has a strong history, then you have to be very, very careful. And then we talked about agranulocytosis, which is decreased WBCs or ANC, absolute neutrophil count, more specifically with the clozapine, clozaril. We have to be very, very careful. Okay, because ANC or neutropenia, this concept is so important from a clinical standpoint of view and also from academic standpoint of view. Lots of questions usually come up on this topic. So I'm gonna have a little bit more discussion on this. First thing is, when you have a neutropenia, which is ANC less than 1.5 thousandths per microliter, look for a cause. You have abnormal lab in front of you. You also have access to their med list and see what is causing, or their diagnostic list. So are they on antipsychotic medication? If the answer is yes, which one? Especially if they are on clozapine or clozaril, right? Are they on any chemotherapy? Do they have any type of cancer, such as maybe MDS and myelodysplastic syndrome? Anything that can cause bone marrow suppression can cause neutropenia, or that will cause actually pancytopenia. Everything will be low. Do they drink alcohol, in like a substance use disorder type of deal? Do they have hepatitis, rheumatoid arthritis, and so forth? Can they have more than one thing at the same time? Absolutely. Then you carry that risk, right? Why is this important? Because remember, ANCs are your absolute neutrophil count. These are your mature white blood cell soldiers ready to fight against infection. And now if they have a sore throat or some minor infections and their ANC is low, they may not be able to recover or fight against that infection. So it's a huge problem. We do have a program called REMS that's designed by the FDA, and we register our patients who are on clozaril, and we do weekly, ANC levels, WBCs. We check CBC, of course. Okay, so there was a time when pharmacists were able to enter ANCs on a weekly basis, and that's not the case anymore. They assigned this responsibility back where it belongs, and that's a clinician. Whoever is prescribing the medication is responsible to manually enter the information into the REMS program. And I am certified, and I have a lot of patients on clozapine, and it is our responsibility to enter the information on a weekly basis. Okay, so what happened is we will order CBC, and you can count ANC. Very simple formula. You multiply your total WBCs and with the total percentage of neutrophils, and you will get a neutrophils percentage when we order CBC with the differentials, right? So for fun, even though nowadays the lab will calculate that for us, but if somebody asks you how to calculate, now you know the answer. You multiply your WBCs. For example, let's say white blood count is a 4.5 for patient number 1, and their neutrophil is a 35.8. You multiply that, and because it's a percentage, you divide that by 100, and I like to round to the nearest tenth. So what should be the answer for number 1? I'll let you pause for a few seconds, and hopefully you got the answer, 161.11, and when you round to the nearest tenth, it's 1.6 thousandths per microliter. For second example, WBC 4.9, neutrophil count is 71, and the answer should be, you can multiply, I'll give you a few seconds, and it should be 347.9 or 3.47, or I'll call it 3.5 to be honest with you. Okay. For number 3, 4.3 multiplied by 42%, that's a neutrophil count, so ANC will be 180.6 or 1.8. Number 4, 3.2, and neutrophil is 30, that should be 96. I'll simply divide that by 100, we'll call that 0.96. So now you know how to calculate that. Let's see, normal range for ANC is 1.5 to 6.0. Right, so any number below 1.5 is considered abnormal. So on severity scale, any number from 1.5 to 1.0 is considered mild, and when you drop that number from 0.9 to all the way to 0.5, that's moderate, and any number below 0.5 is considered severe, especially if you have a fever. ANC of a 0.5, which is 500 is a 0.5, but it's a different units, by the way, so be careful. Sometimes they'll say it's a 1500, that's 1.5. 2500 is 2.5, right? So that's a medical emergency. Patients should not be treated as an outpatient, send them out. And agranulocytosis is a total absence of granulocytes, so that's a 0, which I have seen it. My background was back in the days hematology and oncology, and this is not well common especially when the patient is going through chemotherapy, let's say. Of course, at that time you refer to hematology of ANC that is persistence, and you cannot explain that, and it's below 1.0, and you believe it's not because of any of the medications that we are causing and we are giving, then that's a referral. And depending on the cause, sometimes they can give a growth factor like Neulasta, Neupogen, very expensive. Not always, but extreme cases, reverse isolation, so that we can protect them from infections. Very briefly, I'll mention benign ethnic neutropenia. There is a condition that we believe that in some ethnic groups, they actually have a low level of ANC, and that's their normal. And when we enter these patients in REMS program, they actually ask for ethnicity as well. So, for example, African descent, and in the Middle East as well, their ANC is lower than other population. So it's more, this phenomenon is more common in men, and they have a normal hematopoietic stem cell, by the way, numbers. Just because their average ANC is low, that does not mean that they're at risk of infections. That's their normal. Okay, so they're healthy and they do not have more infections or anything like that. And so that's important to keep in mind, right? So these patients are not at increased risk for developing a clozapine-induced neutropenia. So the system will calculate once we click that, once we acknowledge that in the REMS program. Additional evaluation may be needed to determine if baseline neutropenia is due to benign ethnic neutropenia. Just do not automatically assume. Go back to their previous CBC. If the previous CBC showed maybe 5 years ago the ANC was, I don't know, let's say 3.5, and now it's 1.5, you cannot say that's their normal, right? Because now you have a higher number. So that required some investigation. Okay, so I do want to spend some time on another very important topic, and most likely you're thinking that, gosh, everything is important for this guy. What's wrong with him? But on a serious note, I truly believe this is important and very sensitive topic, and I often come across this situation where my colleagues and even students sometimes they complain or they report, and rightfully so, maybe, that what can we do? The patient is non-compliant. They're not taking the medication the way we're asking them to do. And I hear you. I totally get that. As a matter of fact, I'll tell you that most of my issue is that when I prescribe the medication, when I discharge them in a stable condition, and when they come back in 3 months, 6 months, and so forth, they are not taking the medication, at least not the way I prescribe them, right? So I get it. There's a huge issue, but I think we should understand why, though. It's so easy to blame people, and instead of doing some further investigation. I don't know about you, but me personally, I don't want to take a medication for long term if that medication is causing dry mouth, nausea, weight gain, my A1C is high, my lipid panel is high, and then I mean, I don't want that. These are not M&Ms, right? And on top of that, let's think about it. Um, Especially when you have a client who has a schizophrenia, they believe that nothing is wrong with them, right? So they truly believe those delusions are real, right? They firmly believe in that. Why would they take a medication for something that they believe is real? It seems like the problem is with us, right, as a clinician, not with them. As a matter of fact, they'll tell you that we have incorrect diagnosis for them, right? We don't know what we are doing. So I totally get it. These medications do not make them feel good, right? At least not in the beginning, or at least when they are when they're disoriented, they do not believe that. So I totally understand the concept. Okay, so now we know that the problem is real, it's a genuine. What can we do as a professionals? Number one, do not judge them. Remain non-judgmental. I think it's a very, very important. Let's focus on the problem. Is it possible that they did not take the medication simply because of a GI side effect? Is it because of the cost, transportation? They were not able to pick up the medication, not able to afford copay, right? And do we have them on a very complicated regimen? Are they supposed to take this medication 2 times a day or 3 times a day? I actually, to be honest with you, came across a med list a couple of weeks ago, and it says Depakote 250 milligram 4 times a day, and I go, why can't they increase the dosage and give them, if not once a day, at least 2 times a day for that guy, right? You're really setting this patient for failure. I don't have a time to take a medication 4 times a day, or I wouldn't even remember to take the medication more than once a day, right? Okay, so can we simplify that regimen? Can we decrease that pill burden, if you will, right? And my favorite strategy is long-acting injections. I love those now. And the facility that I'm at, I'm so proud to say that we developed this protocol a couple of years ago, and we changed where I try my best to identify people who are at risk, who I believe have a history of non-compliance, and then I encourage them to use these long-term injections instead of taking pills 2 times a day, every day for the rest of their life. So this is what I tell them. I understand you're taking, let's say, Haldol 2 times a day. I can give you injection where you don't have to take that medication, PO medication at all, at least not for now. And then the injection will be good for 1 month. Some patients will say, yes, I'm okay with that, and some patient will hesitate, and rightfully so. It's their body. And even though my patients do not have a right to refuse medication, but I still want to include them with this process so that they feel involved. At the end of the day, these are human beings, right? And then it will help me and help them to be more compliant. So I keep those things in mind. Okay, so Haldol comes as a long-acting once a month as IM injection. Abilify is another one. If I see that a patient is on Abilify, and I tell them, you know, I can give you, it's the same medication, it's Abilify Maintena, it's IM injection, it's once a month, and most people will say yes. Risperidone also comes as a risperidone consta, that's one IM injection as well, but that's every 2 weeks. So make sure you understand that part, every 2 weeks versus once a month. I personally prefer every 4 weeks, which is once a month, instead of every 2 weeks. And then the way I sell this is when I discharge you as an outpatient, you only have to go to see your psychiatrist or your psych mental health NP provider or whoever is prescribing the medication. Once a month they'll give you the injection, and then you're good. You don't have to take the pills. But I do let them know that we might have to give pills if we need. Like, it's possible that their symptoms are not managed with a monotherapy, right? So sometimes I do add PO as a second agent, by the way. I personally do not like to add 2 injections. These are long-term injections. Once you give them, you can't really reverse that, right? So I have to be very, very careful. Another important concept here is we cannot just start long-term, long-acting injections in the beginning. We must challenge them with short-term PO medications. Like I give risperidone, just like a 2 milligram, maybe 2 times a day for 2 to 3 days or so. And once they tolerate that medication, then I switch them to injections. And another important point is that we do not give long-acting injections in acute setting. If I just want to treat a patient right now, let's say in the ER setting, I would rather give them either, I don't know, like a Zyprexa, olanzapine. I really should be using generic names, or maybe Haldol, haloperidol, you know, as a PO or something like that, or maybe short acting, but not a long acting. Long acting is when you are going to treat them for longer durations, right, for months and years. Paliperidone, you know, it's very similar to risperidone, to be honest with you, but I love this injection, Invega Sustenna. So I challenge them with the risperidone. Paliperidone actually comes as a PO as well. You can challenge with that as well, but I usually use a risperidone. I feel much comfortable. Then I switch them with Invega, and it's once a month, and you give them for several months, and after that you have a similar drug, Trinza, as every 3 months, and then every 6 months. And that's a beauty. See, every 6 months, and that's 2 injections a year. And I have a bunch of patients that I switched them from like a first generation or some other medication to Invega, and with very good outcomes, by the way. I'm very satisfied, and my facility is also very satisfied, and most importantly, patients and family members are very satisfied as well. Ozedi is another one. It's similar to risperidone again. It's we challenge with risperidone. Now the difference between Invega and Ozedi would be that there are many differences, but the main thing is this injection is a subcutaneous injection versus all of these medications injections were IM injections, and it's once a month. All right, so that's a very good approach in my opinion. Not every patient will agree, but it's worth having a conversation, and I bring this up over and over again. And there are certain patients, they'll tell me that they absolutely do not like needles. They would rather take medication every single day, and that's fine. You know, we will never force these medications to any of our patients. So talking about the side effects of antipsychotic medications, next topic is movement disorders. Now, please understand that this is a very generic, broad term that we use to describe any type of neurological conditions that may affect either voluntary or involuntary muscle movement or muscle control, not just medications, by the way. There's so many conditions that can cause that, right? Parkinson is one of them, any type of brain injury, and of course medication side effects and so forth. But today we are going to focus on medication, and especially the first generation psychotropic medications, antipsychotic medications, even though second generation may cause movement disorders. Keep that in mind, okay? All right, so in order to understand this concept, I think it's important to understand a normal physiology first before we really get into the pathophysiology. So basal ganglia actually play a very important role in this. So what I'm going to do is I'm going to draw brain. I'm going to try to draw a brain, I should say. I'm not an artist, and I totally get that. So let's pretend this is a human brain for a second, and I am going to put a little box in the middle, and I'm going to call that a basal ganglia, okay? And I totally understand this is not how basal ganglia look like, and this is a really silly me of trying to draw things. Okay, that's a basal ganglia. Okay, so I want to make some kind of a movement, if you will, a move, okay? I actually have a water bottle in front of me, and I have an idea that I want to drink some water. I want to just open that, okay? So that idea, the very thought where a thought to initiate a movement actually occurs in a prefrontal area. So I'm going to highlight this area, and we'll call that as a prefrontal, let's say. So what will happen is prefrontal is the area where a thought to initiate any type of a movement occurred first, right? This information will be passed to basal ganglia. So I'm going to ask basal ganglia, hey, I want to open that water bottle, or I want to draw a circle, or whatever you want to do. You want to walk towards the I don't know, towards the gate or whatever. Okay, so what will happen is a basal ganglia actually stores past information, like have I done this before? If I want to ride a bike or whatever, a dance move, whatever, right? So basal ganglia will process that. You know, do I have a past experience? Do I know how to write? Do I know how to walk? That's why when we practice, this is where the information gets stored, right? Okay, basal ganglia will actually consult with hypothalamus first, okay? So the consultation goes here, and hey, you know, we have an idea, we want to, I don't know, open a water bottle or draw a circle. What do you think? And then when basal ganglia consult with the hypothalamus, the signal will go to thalamus after that. So here's the thalamus area, and the signals goes here, and you know, they'll go back and forth, right? Now, what happened here is, I'm going to actually change the color real quick. What happened is we actually have neurons, a pathway, something that we call a pyramidal system, okay? So hypothalamus when send the information to thalamus, and from here the information or signal goes back to the primary motor area. So if this is the primary motor area, let's say, the signal will go towards the primary motor area from thalamus via pyramidal system to make sure that movement is possible, okay? So your pyramidal system has to be intact in order to carry out that movement. Also, what happened is, let me change the color behind, maybe that's not a good color actually, let's see. So if this is the pyramidal system, you actually have something that we call extrapyramidal. This is where the background information occur. So if the purpose is to move, if I'm walking, and that's the pyramidal system job, that's your primary like a voluntary movement, I should say, right? That's a main activity. I'm writing, I'm drawing, I'm walking. That will happen here with the this purple color that I drew. This is a pyramidal system, right? However, when we walk, I'm sure you know that it's more than just walking. We have we maintain posture, tone. Even when you draw a circle, there's a movement, and you know, not just with the fingers, but wrist and then biceps, you know, and muscle coordination. all of that behind the scene choreography actually occurs with extra pyramidal system. And what happened is that you have to have a balance of dopamine and acetylcholine for those activities to occur, right? So I'm going to draw, if this is the balance scale, you must have, let's say, dopamine on the one side, and here's acetylcholine on the other side, right? So on any given day, there's a balance between acetylcholine and dopamine. Now, when you have decrease level of dopamine, let's say on this side, and where do you see decreased level of dopamine? Well, first of all, in Parkinson, right? That's a pathology, decreased level of dopamine. Now, in schizophrenia, we actually have increased levels, so too much, right? Too much dopamine, and that makes sense with the movement. Now, the problem is when we give them antipsychotic medication, and especially remember I said with the first generation antipsychotic medication, you're actually binding very tightly at the D2 receptors. You're decreasing dopamine. So when you see D2 receptors decreasing dopamine, you're actually causing this imbalance, and you see this hypokinesia, akinesia type of a disorder. We're going to talk about that in a minute. Now, on the other hand, if you actually have too much of acetylcholine, what happens is when one side is low, if dopamine is low, then you're going to have too much of acetylcholine, right? So that just makes sense. So that's when you see tremors and so forth. So the treatment will be, if you have too much of acetylcholine, treatment would be to give anticholinergic medications. And don't we do that when we give them antipsychotic medication to treat that a side effect of too much acetylcholine. So if your patient has, I don't know, drooling or just any type of, those side effects, we give them anticholinergic medications. We give Benadryl, right? And for Parkinson, when you have too little of dopamine, we give them a medication to bring their dopamine back up, like a levodopa. All right. So with that understanding, let's move on to the next slide where we talk about different types of a movement disorder. This was just a basic introduction, and there are different types. Okay, this is everything I just said earlier. It's just a recap. We defined movement disorders. I said basal ganglia play an important role. We talked about its role in motor control, posture, coordination, and so forth. We talked about the pathophysiology behind it. It's a dopamine imbalance. And we also talked about antipsychotic medication, especially the first generation antipsychotic medication that can cause movement disorders because they block D2 receptor. All right. Okay, well, generally speaking, we can divide these disorders into two broad categories, if you will. It's really a spectrum. So if you have a low movement, low hypo, kinetic means movement. So for example, Parkinsonism, drug-induced Parkinsonism, DIP, they really used to call EPS, but the correct terminology is really DIP. The reason behind that is because if you just call EPS, and there's so many reasons where you can have similar symptoms, it's important to identify so that we can come up with appropriate interventions if it's a drug-induced Parkinsonism, right? Bradykinesia, that's a slow, that makes sense, it's hypo. When you have muscle stiffness, rigid, right? So that's hypokinetic. And hyper will be opposite, too much, tremors. Akathisia is feeling restless, it's urge to move. Your patient cannot stand still, they cannot sit down, they feel that they just need to keep moving. Now, this is not the same thing as anxiety, by the way. Okay, it's a different concept. It's a feeling of like a feeling of restless, right? Restlessness. inability to sit or still, which is not the presentation of anxiety. Anxiety is more of like internal. I feel anxious within, right? This is more of a external presentation. You can see. Dystonia is sustained muscle contraction or twisting. We'll talk more about this. And TD, tardive dyskinesia, is something that you really want to prevent, right? It's when you do not intervene early on. It's a chronic, it's a long-term, when you have a client with some involuntary facial or a tongue movement. Again, we'll talk briefly about this in a few minutes. Okay, what I'm going to do is I'm going to walk you through with the different types of EPS, like a different spectrum, and then the treatment approach. Remember, EPS is your broad term, right? And within EPS, we have a different sub-classification, different types, if you will. The first one on the list is your DIP, and it's a drug-induced. In this case, it's a first-generation antipsychotic. And as I mentioned before, you can have a case of a DIP from a second generation as well, by the way, especially high dose, right? Okay. Now, the pathophysiology for DIP is going to be, of course, you have a low level of dopamine, and we are causing that, right? Okay, so remember, as a recap, when you have a client with a schizophrenia, their main issue was they had too much of dopamine. We gave them antipsychotic medication and we decreased their dopamine, and now we're dealing with this as a side effect. The best intervention should be to really decrease the dosage, and so that we don't have to add another agent. But sometimes you have to add another agent to treat the side effects, okay? And we'll talk about that in a second. Next is akathisia. We talked about this concept, inability to sit or stand still, acute dystonia. These are your severe spasm of the tongue or neck or face. And I have had maybe a couple of patients in the past several years who reported this, and we were able to intervene early on and decrease their medication. Oculogeric crisis is where you have uncontrolled rolling of the eyes. I actually had a patient last year, and in the beginning, nobody took this person seriously, and that's so unfortunate. But when I was making rounds, it happened to him in front of me, and once you see that, you will never forget. It appears to be that and can be confused with, sometimes misunderstood, that a patient is having seizures. So make sure you really know your patient very well. And in this case, this patient wasn't. It wasn't acute, it wasn't that dramatic, if you will, and we were able to just decrease his medication. So something to keep an eye on, okay? But if it's a really active case, we should send them to the ER and then go from there. And of course, to decrease the medication or change the drug altogether. Okay, so important. What's the treatment for EPS? Well, it really depends. It depends what we are treating. But in general, I just want you to remember cab, like a yellow cab, to really understand these 3 or 4 options that we have. Okay, so pay attention. Look at the screen real quick. You're going to see yellow cab that comes in. That should be your visual clue when you take exam. And what do I mean by that? Well, the first one on the list is cogentin. So if you have a situation where it's a DIP, you can start your patient on cogentin, benzotropine. I mean, I do that a lot, actually, 1 milligram BID, and sometimes maybe once a day. You can start at 0.5 milligram BID. The first step should be, can we decrease the medication? If possible, yes. If not, then add this agent. So just remember, this is for DIP. Now, for akathisia, to be honest with you, the first line treatment nowadays is really to use beta blocker. So even though I have anticholinergic here, Artane, it's expensive, and we usually do not use that, but I don't want to put beta blocker because I don't want to mess up with my yellow cab here, cabby. So it's there for you to remember those 4 drugs, but please understand the first line treatment nowadays for akathisia is really a beta blocker, so propranolol. I usually do 10 milligram 2 times a day. Make sure you have a baseline blood pressure and their heart rate, and keep an eye on that and give patient teaching on that. Okay. Now, for acute dystonia, we have anticholinergic Benadryl. I have that as a PRN. You can schedule that as well. Same principle. Make sure you actually decrease the dosage first if possible. And of course, for this we are going to actually send them out. But I just have this as a placeholder, if you will, so that we can remember these options. So on the exam, if somebody asks you, what is the first line treatment for akathisia, the answer should be propranolol. I used to prescribe cogentin a lot, but now we have new regulations, new guidelines, and they're saying be careful with cogentin because it can really cause like a cognitive blunting, if you will. It's not a good drug as a long term, but if you need it, you need it, of course, right? So if you have a client who's a drooling and tremor, shuffling gait, and you want to give them something to support with those symptoms, I do prescribe that. So keep that in mind. Okay, so the last item under movement disorders is the tardive dyskinesia, TD. Tardive simply means a delayed, like a tardy, late. Dyskinesia is abnormal movements. So these are delayed abnormal movements. What happens is if we do not treat EPS in a timely manner, so that's your DIP, your akathisia, and so forth. If we do not intervene, such as if we don't, give propranolol, beta blocker, or anticholinergic like a cogentin, Benadryl, and so forth, then you will get into this long-term chronic condition that we call TD. The most common cause for TD is going to be our first generation antipsychotic medications, your typical agents such as your Haldol, Thorazine, and so forth, even though we can have this from our second generations as well, especially if we keep increasing the dosage, right? Over time, what happens is these receptors, I'm going to draw, let's say this is your presynaptic cell that is going to release dopamine, let's say. So what will happen is, and this is presynaptic cell, this is postsynaptic, let me call that post, and the space between these two cells are your synaptic cleft. So as we know that we have let's say receptor here, and we'll call this as a D2 receptor now, because that's our main target area for antipsychotic medications. So antipsychotic, let's say Haldol, will bind at a D2 receptor here and block the receptor, right, so that we cannot, so that dopamine cannot attach to these receptors. That's normal mechanism of action of our antipsychotic medications, at least our first generation medications. Now what happened is, because we blocked D2 receptors for a long time, these receptors becomes very sensitive. So if all of a sudden, if there's a dopamine release that's going to bind at these receptors, we are going to see very dramatic response. All of a sudden, this receptor will activate, because this receptor was blocked for a while, and all of a sudden, when I say for a while, I mean for weeks, months, and sometimes years, right? And then all of a sudden you will see very dramatic response, such as involuntary movement, very repetitive movements, even if dopamine levels are normal, right? So I'm not saying that the dopamine levels are high, they're normal, but you have a sensitivity, the super sensitivity of these receptors in the basal ganglia area, right? Because that's our focus of the discussion. We are talking about movement disorder, and then I said that is the role of basal ganglia. So what are these repetitive movements, involuntary movements? Well, that's your very bizarre facial movement, and tongue movements. I remember I had a client a long time ago. He would stick his tongue out as if he's trying to catch a fly, if you will. Very bizarre. And patients get very embarrassed, unfortunately. You will see lip smacking, puffing of cheeks, uncontrolled chewing, excessive eye blinking, or sometimes even very scary, dangerous, like stiff neck, difficulty swallowing. So you can have a client at risk of choking, if you will, right? I'm very glad that nowadays we do not see a lot of cases of tardive dyskinesia, and I believe the credit goes to our second generation antipsychotic medication. There was a time when we didn't have these newer drugs, and almost all of the patients were on first generation high dosage, especially in psychiatric facilities, but even long-term facilities as well. And then there were a lot of patients with a TD. Now we see these clients, but I'm proud to say that with the better drugs now, and with the better understanding, and we intervene early on, we have some medication that we can give, and so we do not see these that often, at least, right? We still have a problem, though. Of course, there's always room for improvement, right? So we talked about preventive choking measures and so forth. The best tool to assess, the two of them, AIMS and DISCUSS. We personally use AIMS upon admission and quarterly, or anytime we need to assess our patient. So just follow the facility protocol. What I'm going to do is I'm going to actually have you watch a video. I'm going to send a link where there are small clips, and make sure you're able to identify different types of presentation of TD and rate them using AIMS. I will send you a PDF copy, and also a video clip for DIP and akathisia and so forth. I could not play those here because of copyright, but I'm going to have you to play on your own time, though. Make sure you really understand. It's important to differentiate DIP and akathisia and TD, because the treatment approach is different. Remember, we were talking about earlier either cogentin, anticholinergic medication. For akathisia, we talked about a beta blocker, like propranolol and so forth. Now, we will not give anticholinergic in the TD setting. That's actually going to make these symptoms even more worse, right? Because we're trying to bring a balance here. So the first approach really should be A, to identify early on, and B, if possible, decrease antipsychotic medication, not increase. We want to decrease antipsychotic medication. We'll talk about that in a second. Here it is. That's the management slide. So as I mentioned, make sure we intervene early on, so that we avoid this long-term issue. And as I mentioned, best management is to actually pick, if possible, second generation medication in a lowest dose, right? But we do have two drugs approved by FDA for these symptoms now. There was a time when we didn't have any, so this is a good time in psychiatry field. So the first drug is diotetrabenzene. Austedo is the brand name, and valbenazine Ingrezza. Both of them they have same mechanism of action. Remember, many weeks ago we talked about neurotransmitters and their packaging material. I mentioned that different neurotransmitter will have different types of packaged in the presynaptic cells. For example, we talked about VMAT1, VMAT2, and so forth. Now, both of these medication, they actually inhibit VMAT2. That's your vesicular monoamine transporter type 2. It's a protein that is responsible for packaging neurotransmitters such as dopamine. That's what we are interested in here, into synaptic vesicle so that they can be released into the synapses. So remember, if this is your presynaptic cell, so these vesicles where these neurotransmitters hold, remember they are called, I'm trying to draw a circle here, but it's not letting me, to be honest with you. Okay, so just pretend this is a nice circle. Okay, so these are your VMAT. So what happened is when you inhibit the VMAT, let me use a different ink. So if you're going to inhibit VMAT protein, these drug will decrease the amount of dopamine that can be released into the synaptic clefts. If you have a less amount available, that means there's a less amount available for our postsynaptic cell, and more specifically for these dopamine receptors. Okay, so that's a very interesting mechanism of action if you think about it. I love this. Very, very neat. All right, so overall, when you have less dopamine, this will help to control these hyperkinetic movement that we see in TD, and even with those chorea associated with Huntington's disease, a very, very similar mechanism of action. So here is the Ames assessment that I was talking about. I'm going to give you a copy and make sure you actually play that video. I'll send you a few clips, and then make sure you really assess the patient using this. This is a good exercise. Okay, now we are done with movement disorders. This topic is totally different what we were talking about earlier. This is actually a very severe side effect of antipsychotic medications. Can be very dangerous, so we must intervene. So it's I intentionally picked red font, if you will, red color, to indicate that this is dangerous. It's important. Neuroleptic malignant syndrome, NMS, important from academia standpoint of view, and of course the clinical standpoint of view as well. So the cause for NMS is, well, any medication, any drug, any agent that blocks dopamine. And also there's a genetic predisposition as well. So even though any drug that blocks dopamine can cause NMS, but more specifically high potency agents, your first generation antipsychotic medications like Haldol, fluphenazine, and so forth. Now, what is the presentation? Well, I want you to take a look at fever. If you remember that part, F is for fever, so all of a sudden elevated temperature. E is for encephalopathy, so mental status changes. Patient may have incontinence episodes as well. Vital signs are going to be unstable. Everything is going to be high blood pressure, tachycardia, diaphoresis. And then enzymes are going to be elevated, CPK enzyme. And look at the last part, rigid. Muscles are going to be rigid. That is the hallmark presentation of NMS. Now, recall from our antidepressant lecture when I talked about a serotonin syndrome. Any agent that can increase the serotonin level may result in serotonin syndrome. And at that time, I gave you very similar presentation, but instead of a fever, it was a vim. At the end, it was M as in Mary instead of R. So what does M stand for with for serotonin syndrome? Well, M was for motor hyperreflexia. So that was your like a tremors, hypertonia, right? Seizures and so forth. This is opposite of hyperreflexia. This is rigid. So that is the difference. So make sure you do not miss Any questions on the boards or on any of the exams? If it's a FEVM, that is a serotonin syndrome. If it's a fever with R, that is your NMS. Very important. Now, what is the treatment for NMS? Well, you stop the agent. So in this case would be antipsychotic medication. Remember, with the serotonin syndrome, the cause was your any medication that increases serotonin, like antidepressant medications, right? SSRIs, SNRIs. Here is antipsychotic medication. And the treatment for serotonin syndrome was actually cyproheptadine, remember? And in this case, the treatment approach for NMS is going to be your dantrolene or bromocriptine. So please remember that. Dantrolene is going to act as a muscle relaxant. It's going to relax because you have muscles are rigid here, and this will bromocriptine will act as a dopamine agonist. Remember, so here we are blocking dopamine. That was the cause for NMS. So we need to reverse that. Very important concept. Okay, so now let's talk about anticholinergic crisis. So what happened is you can have a client who either overtook those medications, like antipsychotic medications or some anticholinergic medications, and or maybe you have a client who's very sensitive to those drugs. So you can have anticholinergic crisis, way too much anticholinergic going on. That means you don't have enough acetylcholine, right? Because this is anticholinergic. So you will see decrease acetylcholine. Now, remember, acetylcholine is your cholinergic, right? So acetylcholine was supposed to cause GI secretions, watery eyes, mouth is watery, and all those, peristalsis and so forth. But if this is anticholinergic, that means you don't have enough acetylcholine, means everything's going to be slowed down, right? Very dried up. So the signs and symptoms are going to be hot as a hare, blind as a bat, mad as a hatter, and dry as a bone. So the first thing we should do is we need to discontinue the medication, and then symptoms usually disappear or get resolved within a couple of days or so. DC medication, that's a part of the treatment plan, or plus minus, depending on the severity of the case. We might have to introduce physostigmine, which will bind at the enzyme acetylcholinesterase. This is enzyme because it ends with ACE, right? So remember, when you have a neurotransmitter that enters into the synaptic cleft, and there are enzymes that will destroy the action of acetylcholine. Name of the enzyme is acetylcholinesterase. This drug will actually bind at those enzymes so that you're not able to destroy acetylcholine. So the end result will be that you have a more concentration of acetylcholine in the synaptic cleft, or at least acetylcholine stays there for a longer duration. Sometimes that's all you need to improve those symptoms. So that makes sense. So or sometimes we might have to do gastric lavage and maybe charcoal and so forth. Anyways, the point here is stop the medication, use some reversing agent, or give a medication to reverse the destruction of acetylcholine, because the end goal here is to actually give more acetylcholine, because we are in anticholinergic crisis, right? We need to reverse this. Okay, well, this is totally opposite of what we have been talking about. This is cholinergic rebound. So if you have a client who was on anticholinergic medication for a while, and all of a sudden they stop taking those medications, especially if they stop taking all of the anticholinergic medication that they were taking. So you will see a lot of increased level of acetylcholine, right? So because it's a cholinergic rebound, so that's not good. So what will happen is all of a sudden you will see your nausea, vomiting, excessive sweating, and so forth. Some people may enjoy these symptoms, especially if they get that mild euphoria, if you will. But you can have a client who reports delirium and hallucinations and so forth. Okay. Next on the list is a drug reaction with eosinophil and systemic symptoms, something that we call DRESS. It's very rare, but life-threatening drug-induced hypersensitivity reaction, usually associated with the geodon, but I guess it can actually occur with any antipsychotic medications. So what happened is all of a sudden you have these skin lesions, eruptions, and you're going to have evidence of eosinophilia, lymphadenopathy, and some internal organ involvement as well, like a lung, liver, kidney. Needless to say, this is the very severe drug reaction. The first thing we need to do is we need to discontinue the medication altogether and give supportive management, IV, prednisone and steroids, I really should say. Keep an eye on this and do not challenge your patient on the same drug. All right, well, let's see if you were paying attention or not. Okay, so the first question is, which of the following symptoms are important in assessing a client who's going through akathisia? Option A, resting tremor. Option B is a motor restlessness. Option C is a mask-like face. And option D is a shuffling gait. I'm going to have you pause for a few seconds and see if you can answer the question. All right, well, the right answer is option B, motor restlessness. Everything else, such as resting tremor, mask-like face, or shuffling gait, are actually symptom presentation of somebody who's going through Parkinsonism type of a presentation, right? In akathisia, you will see restlessness, such as pacing and rocking and shifting from one foot to another, right? Okay, now let's see. Okay, so next question is, all of the following symptoms are present in a patient who's going through NMS, neuroleptic malignant syndrome, except A is a diaphoresis, and B is muscles are rigid, and number 3 is incontinence, and option 4 is motor hyperreflexia. I'm going to have you pause again for a few seconds and see if you can come up with the right answer. And option D is the correct answer. You guys are so smart. So remember, we were looking for except. All of these options are actually a part of the NMS, but option D is the option that will suggest serotonin syndrome, not NMS. All right, well, let's play to truth and a lie. Number 1, hallucinations and delusions are examples of positive symptoms of schizophrenia. So what do you think? Is this a true statement or false? Clozapine or clozaril can cause agranulocytosis, true or false? And then number 3 is a person with schizoaffective disorder. They experience the symptoms of schizophrenia and an anxiety disorder. So what do you think? Out of these 3 options, which ones are true statements and which one is a lie? Can you please identify that? Again, pause for a few seconds and come back. And here is the answer. These are the positive symptoms. We know that. Clozaril can cause agranulocytosis. That's why we monitor ANC. We talked about that concept in depth. And schizoaffective, this is your schizophrenia and affective disorder, which is a mood disorder, not anxiety disorder. All right, I think you got this correct. And we are officially done with this topic. I hope you enjoyed this as much as I enjoyed recording this presentation. If you have any follow-up questions, please do not hesitate to contact me, and then I will see you next time with a different topic. Thank you.